Patient is a 3-year-old girl with extremely tender abdomen and fever. Patient has not passed stool for the last 2 days. Abdominal pain for over a month, but it has increased in intensity for the last 1 day. Fever 1 day. On ultrasound, we found a large midline septated cyst with echoes. It is in the lower abdomen and the upper pelvis. It measures 7x8x4 cm. There is no solid component in it. Overall septa are thin and complete. No invasion to surrounding structures. Mass effect is noted on small gut loops. Mild mass effect is noted on the dome of the U-bladder. Lesion looks like in the lower portion of the small gut mesentery. There is no fat or fat fluid level in it. No calcification. No hemorrhage. Gut loops are not dilated. Channels and both kidneys are normal. No para-aortic lymphadenopathy seen. What could be this lesion? What would be differential? How to proceed to conclusion? The described lesion in a 3-year-old girl with fever, acute worsening of abdominal pain, and constipation, along with a large midline septated cystic lesion in the lower abdomen and upper pelvis, raises concerns for several differential diagnoses. Possible differential diagnoses: infected mesenteric cyst, most likely given fever, tenderness, and location. Mesenteric cysts are rare, benign intra-abdominal cysts that arise from the mesentery. Septations, internal echoes, and mass effect are common. Infection/inflammation can cause tenderness and fever. Omental or mesenteric lymphangioma can present as large, thin-walled, septated cystic masses. Typically non-tender, but if infected or hemorrhagic, can cause pain, fever. Duplication cyst, enteric or colonic, often located in the small bowel mesentery. Septations, internal echoes, due to secretions. May cause obstruction, volvulus, or infection. Abscess, infected cystic lesion. If the cyst is truly infected, it could represent an intra-abdominal abscess, secondary to a perforated duplication cyst or infected mesenteric cyst. However, the absence of surrounding inflammation makes this less likely. Ovarian cyst, unlikely due to midline location. While large ovarian cysts in young children can occur, this lesion appears to be more in the mesentery rather than adnexa. Hydrometrocolpo, less likely, typically seen in imperforate hymen or vaginal atresia. More midline and posterior, pushing the bladder upward. EXT steps to confirm diagnosis, clinical correlation. Any signs of peritonitis, guarding, rebound tenderness. Any history of diarrhea before worsening? Any urinary symptoms, to rule out hydrometrocolpo? Any previous episodes of mild abdominal pain? Blood work: CBC, CRP, ESR, check for infection/inflammation. Lactate, rule out ischemia. Electrolytes and renal function, assess overall condition. Further imaging: contrast enhanced CT or MRI abdomen/pelvis to assess vascularity, true origin, and extent of the lesion. Helps rule out malignant features. Aspiration, if needed. If infected cyst is suspected, an ultrasound-guided aspiration may help confirm pus versus clear fluid. Biochemical and cytological analysis can differentiate lymphangioma, chylous, duplication cyst, mucinous/acidic, abscess, purulent. Surgical exploration, if indicated. If symptoms persist or there is uncertainty in diagnosis, exploratory laparoscopy/laparotomy may be needed for definitive diagnosis and treatment. Most likely diagnosis: infected mesenteric cyst or complicated duplication cyst given the location, large size, septations, echoes, and fever. Needs close monitoring, possible antibiotics, and surgical evaluation if worsening. Management options based on diagnosis: 1. If it is an infected mesenteric cyst, supportive care, 4 fluids, 4 antibiotics, covering gram-negative and anaerobic bacteria, example ceftriaxone plus metronidazole, pain control, paracetamol/NSAIDs. If no contraindications, definitive treatment, If the cyst is large, symptomatic, or infected, surgical excision is required. Laparoscopic versus open surgery, laparoscopy preferred for uncomplicated cases. Open surgery may be needed if cyst is large, adherent, or infected. Aspiration alone is not recommended, as recurrence is common unless entire cyst wall is removed. If it is a duplication cyst, observation, only if small and asymptomatic, surgery, if symptomatic, infected, or causing obstruction, cyst excision with or without bowel resection, if bowel involvement. If bowel resection is needed, primary anastomosis is done. Laparoscopy versus open surgery depends on size and location. 3. If it is an omental/mesenteric lymphangioma, if asymptomatic, rightward arrow follow up with ultrasound. If symptomatic, pain, mass effect, rightward arrow surgery. Complete surgical excision preferred. Aspiration alone is not effective due to high recurrence risk. If there's bowel obstruction or peritonitis, emergency surgery if patient develops peritonitis, guarding, rebound tenderness. Bowel obstruction, vomiting, distended abdomen, worsening constipation. Septic shock, high fever, tachycardia, hypotension. Surgical options, excision of cyst. Bowel resection if need. Monitoring and follow-up, post-op recovery usually smooth if cyst is completely excised. Histopathology is mandatory to confirm diagnosis. Regular ultrasound follow UPS if cyst was incompletely removed or if lymphangioma was suspected. The three main differentials for this large, septated, cystic lesion in the lower abdominal mesentery are, 1. Mesenteric cyst, most likely. Key features, large, thin-walled, septated cyst. Can cause mass effect on gut loops, may become infected, rightward arrow fever, tenderness. Next steps, 4. Antibiotics if infected. Surgical excision is definitive treatment, aspiration alone has high recurrence. 2. Enteric, duplication, cyst. Key features, often closely related to bowel, small intestine. Secretions, rightward arrow internal echo seen on ultrasound. Can lead to obstruction, infection, or hemorrhage. Next steps, surgical excision is needed if symptomatic. May require bowel resection if intimately attached. 3. Omental/mesenteric lymphangioma. Key features, multiloculated cystic mass, often large. Usually not tender unless infected or hemorrhagic. Contains chylous or serous fluid, no fat/calcifications. Next steps, if asymptomatic, observe with ultrasound. If large or symptomatic, surgical excision. Less likely differential diagnoses, abscess, rightward arrow unlikely due to lack of clear signs of pus or inflammation. Ovarian cyst, rightward arrow unlikely due to midline mesenteric location. Hydrometrocolpo, rightward arrow unlikely, as bladder is not significantly displaced.